So let me proceed to introduce Professor Andrew Tomkins, who we've had on ICMDA webinars before. Andrew has worked abroad in Nigeria and the Gambia in tropical pediatrics and was formerly based at the Centre for International Child Health, now known as the Institute for Global Health at University College London. Andrew has assisted UNICEF, WHO, the World Bank, and also national governments in the development of their child health and nutrition programs. And with Tier Fund and overseas partners, he's worked to develop church-based programs for prevention, treatment, and care of disease. So that's his clinical background. He's now technically retired, although for Andrew, who doesn't really know how to do retirement, that means that he's presently supporting a whole host of other programs in northern Nigeria, Ethiopia, South Sudan, and Zambia. Andrew is also a member of the Global Committee of the Christian Medical Fellowship of the UK, and it's in that capacity that he's speaking to us today. He's chaired a working group on corruption in healthcare, which produced a paper titled Conflict of Interest and Corruption in Healthcare, which is available on the CMF website. So it's my pleasure to introduce Professor Andrew Tomkins to speak to us on corruption in healthcare. Thank you very much, Andrew.
Well, thank you so much, Peter, and greetings to everybody who's on this webinar. I would like, as Peter said, to acknowledge at the very beginning the enormous work of the Global Committee in writing this important paper, because there can be very few people working in healthcare in any country in the world who have not been affected by conflict of interest and or corruption. It's certainly been my experience, and I'm going to share some of that with you. But what I'm going to be doing is drawing out some of the key issues, perhaps for you to think about and discuss with your colleagues. And the second thing I would like to say is that Transparency International, an excellent organization which monitors the scale of conflict of interest and corruption, has also been very instrumental in producing materials. I should just at the beginning, if I may please, just say that all the comments on these slides are the views of the authors only. They're not of the organizations or the governments in which they work, for obvious reasons. Yeah, how do we define conflict of interest? Well, I've basically looked at it at the left hand, knowing what the right hand is doing. In the left hand, we see the primary goal of all our work is improving the health of patients. But at the same time, there are lots of situations in our lives, our professional lives, where there is a potential goal of increasing our personal gain. And that's really what it is, when one comes into conflict with the other. And perhaps we don't really think about it, but I just wanted as an example to give 5 situations that are widely experienced. I'm aware that these are very difficult areas, particularly for those who are on low income or those where the level of conflict of interest and corruption is endemic in society. And for that reason, I'm not going to choose particular countries. I'm going to use the global issues. So I'd like to give you just 5 examples. The first is experienced by many. Unfortunately, I don't know about your experience, but certainly it is the experience across the world that continuing medical education is a real problem to obtain. Governments are short of cash, or they do not wish to give it. And having a pharmaceutical company come and offer to give a seminar or a lecture is something that many people would jump at. But we've got to mention that every time that we attend such occasions, we are having our brains affected by the information that's given, and it needs great discernment. Second example is when infant formula companies provide meetings or subsidize travel. Now, perhaps I should just introduce this by going back a bit. In 1981, the World Health Organization instituted their code, their international code of breastfeeding marketing. Very clear, and you can look at that on the WHO website. But in 1998, just a bit after that, I and some other research colleagues did a review of the violations of this international code of feeding, marketing of breast milk substitutes in 4 countries: Bangladesh, Poland, Thailand, and South Africa. This was published in the British Medical Journal. The reference is there, and you go and look at it. And there was a really horrific level of payment, of gifts, and persuasion for mothers not to breastfeed, but to bottle feed. And we know very clearly, it puts those children at risk. Now, just bringing you up to date, literally in the last week, there's been a letter published in The Lancet. This is online, it's free access. You can look it up after this webinar, on marketing of breast milk during the COVID-19 epidemic. And there's information given in this letter that supplies are being given in Canada, India, Italy, Pakistan, Philippines, and the UK, which violate the code. So one of the issues, therefore, is how does one respond to money for all sorts of activities, such as attending or setting up a meeting? Well, in the 2 years after our British Medical Journal paper, I tried to persuade the Royal College of Paediatrics and Child Health to stop accepting money, and I was voted out. People wanted to continue to take money from the formula companies. But I'm delighted to say that in 2019, on the 13th of February, the Royal College of Paediatrics and Child Health changed its mind, and now they do not take money from formula milk companies. And interestingly, the British Medical Journal doesn't take money either. The other interesting is when industry pays for research. There is an excellent objective review system called the Cochrane Library. And this again is widely available to anybody globally. It does objective reviews of treatment. It's particularly looking at antibiotics, anti-cancer, all sorts of treatments. In 2017, they reviewed the outcome of papers for assessment of medical technology. And they looked at the results, the studies that had been funded by industry, as opposed to studies that had been funded by local health authorities. And perhaps not surprising, they were much better outcomes when they were funded by industry. Something that perhaps we don't necessarily consider is the favoritism through providing better health care for friends or from same faith groups. Sometimes people want to push into your outpatient clinics. They want to see you when you should be doing something else. Again, that is a conflict of interest that we might consider. And the fifth one is the gifts of medical equipment from companies. These are really very much valued, particularly in some of the very resource-poor situations that I've been working in from time to time, but they come with a sting in the tail. These gifts always have something, they've altered your mind. Now, people ask how widespread is conflict of interest, and obviously it's not known completely, but there is some very interesting data. The United States of America has a very interesting law called the Physician Payments Sunshine Act, and it actually declares the amount of money that is given to physicians by pharmaceutical companies. And in 2017, 10.7 million payments were given to doctors with an overall bill to the companies of 2.8 billion US dollars. Massive. But at least the advantage there is that the amount given is open. So much so that when you look at the money given to US-based physician editors of major journals, 64% of them received money. Interestingly, the Scottish Parliament in the UK, which is thought to be one of the perhaps more conservative organisations, they had a proposal for a similar bill, such as the Sunshine Act, recently, but it was refused, it was turned down because it was regarded as an invasion of personal information. I leave you to draw your own conclusions about that. So what's the impact of conflict of interest? Well, three. Firstly, doctors may fail to advise the most cost-effective evidence-based treatment. And that leads on to number two, which means a reduced provision of effective basic healthcare for the public, especially for the poor who can't get access to it. And thirdly, something that is a personal thing, is disagreement and mistrust. I have been really quite horrified and shocked at the level of disagreement and anger and mistrust between individual doctors who take either no view about conflict of interest and they say it's not a problem, and those who would like to explore it. Let's go on to the second dimension of the paper, definition of corruption. I've used the World Bank definition, which is the abuse of power for personal gain. Now, Transparency International has three categories of corruption. I'm only really going to talk about the third, but just introduce what grand and political are. Grand is basically theft. It occurs in mega scales, such as the recent admission that there were billions of dollars of money lost in Kenya. It could have been any country because there are plenty of other examples. That's grand corruption at a major level. The second is political corruption, where bribes for contracts occur, and that may occur at a very senior level in government. It may occur at a district health authority. It may occur in a hospital or in a community health setup, but I'm not going to go into those. I'm going to really focus on 6 examples of personal medical malpractice. The first is one that was widely shared during the research leading up to the writing of this paper, the nurse being told by the doctor to tell a patient, a grateful patient, as you see from the picture, that it's normal to give a present of appreciation to the doctor. And this is tough when you are receiving a very low salary, but it is corruption. Secondly, our minds are affected by all sorts of things. Sometimes, as we've already discussed, through the conflict of interest, through promotion of advertising, but we may also be influenced by cash. And there's no doubt that there are many examples where treatments are given as a result of being given money to the doctors. Charging for unnecessary treatment is obviously one which is in the category of corruption. This is an interesting one, and certainly one that I've been exposed to, asking for or giving extra cash for a fast-track procedure. If you are working in a university, you apply for ethical approval for research, whatever the research is, but in some places you are told, sometimes quietly, that if you pay the extra cost, you can get the ethical approval very quickly. This is sometimes a real problem for those people who are working. Perhaps they live in one country and go to work in another country. We live in a world where doctors and nurses move across boundaries very easily, but obtaining work permits may be very difficult, and paying bribes to obtain permits is just one of the examples. This may be a shock for some of you, but some of the experiences that were shared with us in the European practices, this is not global, but we were talking about what happens in some European universities, that it is normal practice to bribe lecturers so that you pass exams. Now, those are the lists. We could go on, but I just wanted to raise those as examples for us to discuss. And I've been exposed, having lived or worked in Africa for many years and visited Asia many times. I want to just give you two of my own personal experiences in corruption. And I say this to my shame. This one was when I was working in a rural hospital in an African country for some years. I paid for fuel for the water officials to reconnect water. We had not been able to do any surgery for 3 days because we had no water. We'd had quite a number of deaths. I was desperate, and I was told the only way to get water connected was to pay, and I did. You may criticize me, and I perfectly accept that. My second one is that I paid a fast track fee to clear medical supplies for the hospital and the projects, together with a few personal belongings. And if I had paid the normal rate, I would have had to have waited quite a long time. I apologize for that phone. And as you can see, there was a problem with the fact that I was paying fees when actually I could have waited. So if you want to look at further personal case studies of corruption and conflict, they are on the paper. There are basically 15 which would are there. And I would just suggest that you might like to look at them from the point of view of what would I do? And that is saying that. So there's not a judgment about right and wrong. That is for you as a group of people to look at those and make up your minds. So how widespread is corruption globally? It's unknown, like conflict of interest. But Transparency International found that in 17 countries, in Europe, Africa, Asia, and South America, 70% of the public believe that healthcare is corrupt. Interestingly, in my own country, there's a very interesting review by the Royal College of Physicians, and you can Google Royal College of Physicians UK and look at the 2019 meeting, where specific examples of conflict of interest and corruption in research in the UK are clearly defined. And tragically, corruption adds, in the estimate of the World Economic Forum, a considerable amount to the costs of services provided globally. Again, what is the impact of corruption? I think the first three relate to our patients, and the second two relate to ourselves. Clear impact of corruption, it means that there's going to be less healthcare because somebody's stolen the money or somebody's taken money away and it's not in the provision of healthcare. Secondly, it reduces access to healthcare. And that's a really important thing, particularly for the poor. It's interesting that the World Bank has actually said that in, I think it's Paraguay actually, 12.6% of the average household income of poor people is spent on bribes, compared with 6.8% of better off people. Poor people have to pay to get access to healthcare. And that results, as we see in item 3, a worse health status, especially for the poor. There's two things which actually refer to us and our own being and our own trustworthiness and our own witness. The first is that it reduces our personal moral integrity. And once our personal moral integrity is reduced, then we are not trusted. And that, to lose the trust of people, whether it's patients or whether it's colleagues, is a terrible thing. It's interesting that there have been various attempts to reduce conflict of interest in the UK. we have an organization called clinical commissioning groups, whereby groups of hospitals and family practices work together to provide services. And they're supposed not to promote infant formula. But a Channel TV program showed that 59 out of 195 clinical commissioning groups broke the WHO code of practice about breastfeeding. The Telegraph, which is a daily newspaper in the UK, revealed that pharmaceutical companies in 1 year gave £116.5 million to UK doctors, and only 1 in 3 doctors declared them. And thirdly, the British Medical Journal found that a very important number of clinical commissioning groups failed to declare financial support from pharmaceutical industry. So why are conflict of interest and corruption not taken more seriously? Why isn't it in our conversations? We have all sorts of ethical discussions, we have all sorts of practical and professional discussion, but conflict of interest and corruption are not widely discussed. I think there are at least 4. I'm sure you guys can think of more. The first is, it does not appear on the curricula of medical schools. Negotiating one's way through life as a doctor or a nurse or other health professionals is tricky. It's important to get it right, but it's not in the training. Very rarely is it included within job appraisal, where people are assessed by their supervisors for the work that they have been doing during the last year. Thirdly, there's often a secrecy culture among many health professionals in which they wouldn't want to talk about money, even though it's coming in by all sorts of routes. And fourthly, it is often endemic in our society, and it damages our society. Just to begin to finish, are there any guidelines? Well, there are some excellent principles called the Nolan Principles, which were set up, I have to say, they were set up for public service in the UK, but they are, as I see them and our colleagues saw them, universally applicable for selflessness, for integrity, for objectivity, for accountability, for openness, and honesty and leadership. And it might be that we would do well to seek to score ourselves on these 7 indicators of our service as doctors. Now, as Christians, we need to be guided by what the Bible says about corruption and conflict of interest. And it's absolutely clear. Isaiah speaks about working for justice and enabling the poor to have their rights. Deuteronomy, absolutely straightforward. Do not accept bribes. To Chronicles, very interesting, very perceptive. Make wise decisions without bribes. Just emphasizing something was known hundreds and hundreds of years ago, that our professional work can be influenced by money. A tough one, this, Ecclesiastes 7. It recognizes that bribes damage the receiver. It isn't just that society is damaged. It isn't just that our patients are damaged. It is we are damaged by corruption as individuals. And that's something that could be explored in a group. And then we need to ensure good leadership. I used the word personal moral integrity, and this is just something to sum up at the end. If we look at ourselves or any individual in the world, there are 3 dimensions at least in terms of what drive us. The first is conviction. That is, what do we actually believe? The second is intention. That is, what do we feel we ought to do to change things? And thirdly, action. Do we actually change things? And we could score ourselves by trying to assess conviction, intention, or action in our lives. Just the last couple of slides. Being a doctor or a nurse or another health professional is a wonderful thing. We would all, I'm sure, agree with that. But if we're going to walk honorably, it's dangerous. And we've got to be aware that we may make mistakes. But we can be aware of these and we can respond accordingly. And my last slide just perhaps seeks to summarize a very complex area into just 6 points. I think for me, and these are very personal, I have to say these are the ways that I have to look at things. Be aware we can behave corruptly, any of us. Secondly, be aware that we may have conflicts of interest. Perhaps we don't even recognize them. Thirdly, we could be more honest in admitting them during our appraisals. I've had appraisals over the years by people senior to me, and I've never been asked about conflict of interest or corruption. On the positive side, we can promote supportive openness. There are wonderful opportunities for small, confidential, supportive groups of doctors and other health professionals to work together and be supportive as they seek to identify and explore and make action plans for how they would respond to these issues. And that means practicing with personal moral integrity according to those principles, biblical principles that are outlined so very clearly for us. And finally, that means that we can behave honorably, especially under pressure. So thank you very much. I'm aware that I may have touched on some raw nerves. I just want to say that I am somebody who has been exposed to these, and I could have responded with better integrity, but it's something that I hope we would find valuable to share and to support each other as we behave honorably in our clinical practice. Thank you very much for listening. Over to Peter.
Thank you very much, Andrew. We've been listening to Professor Andrew Tomkins from the UK speaking on corruption in healthcare. And thank you, Andrew, for an incredibly comprehensive and challenging presentation, not just on the principles, but to all of us personally, because this is a worldwide problem. So let's move to the questions now, Andrew. And the first one is about pharmaceutical sponsorship, which you mentioned right at the beginning of your talk. When does pharmaceutical sponsorship become corruption? Isn't it really just marketing or salesmanship, trying to get their products out to market influencers like doctors, dentists, and allied health professionals? So what's the difference between sharing information and corruption or conflict of interest?
That's a really important question. It's one that I've been challenged in my own life. When I've had to organize meetings or I've attended meetings, one has to ask this. I suppose for me, the key answer would be, how much does it affect my decision making? How much does it affect my decision making? That is the crunch issue. If, for instance, I was able at the end of a meeting, which had been funded by the pharmaceutical industry, to say, yeah, I've got a lot of information about different drugs, different drug companies for any particular illness, that would be okay. But if it was such that I knew that as a result of that meeting, I was more likely to prescribe one particular drug, then that would definitely be conflict of interest.
Thank you. Next question from a name you'll recognize, Andrew, Hugh Morgan, who I think is also a member of this committee. And Hugh asks, in my experience, what's regarded as corruption is culturally influenced. For example, in some African countries, a person who handles an organization's money has a duty to use it to help need in their family. This may not be regarded as corruption in other cultural contexts, whereas in some cultural contexts, whereas in European countries, it certainly would be. Any comments on that, cultural differences in how we define corruption? Is this something that crosses all cultures, or are there different rules in different contexts?
Well, I think it's a really, really important question, and I do hope that people might follow up my suggestion of perhaps small groups of people discussing some of these topics in their groups. For me, the issue comes back to the patient. How much has the transfer of money affected care to the patient? If it means that we are basically less likely to be able to prescribe or less likely to provide services, then that money must either be guarded as conflict of interest or corruption. If, for instance, it means that a person is bumped up the queue of outpatients and they got more likely to see the doctor, that surely must be regarded as conflict of interest, or in that one, corruption. So I think trying to discern whether this is culturally applicable as normal behavior, or whether it is really conflict of interest in relation to patient care, I would always ask the question, how much has any transfer of money affected the thinking of the doctor and the healthcare provided and accessed by the patient?
Thank you. Next question from Marissa Resulta in the Philippines. During the start of the pandemic, our country and even hospitals in my country were not prepared for the increased need for PPEs for healthcare workers. We relied mostly from donations from the private sector, some of which were from pharmaceutical companies. Would you classify these donations as a form of bribery and corruption, or might there be circumstances in which that wouldn't apply?
That's an incredibly important question, and it's one we've obviously looked at. It's very difficult, because when you've got large numbers of patients without PPE, I know that where I'm living at the moment in the UK, it's been charities who've been giving PPE. I suppose the question in an emergency like that would be that would be acceptable. I suppose what would be unacceptable would be if the donation of PPE or any other emergency related resource would be linked to making sure that future purchases of drugs were linked to that gift. And that's one of the things that came on about the gift thing. When anybody gives you, whether it's a charity or whether it's a pharmaceutical company, if that gift comes with an expectation that something else is going to be given back, then that becomes conflict of interest or corruption. If it's given without expectation, I would see provisionally that doesn't have that same level of terminology.
That leads on to our next question, anonymous question. Should we say no when patients give us gifts?
That's a really...
In what circumstances should we and shouldn't we? You partially answered this one already, but this is more about the individual doctor being given a gift or a present.
Yeah, now this is a really important question. What happens in some countries, and I can tell you what happens in the UK, there are very clear guidelines about what the amount of money or the gift is worth that can be accepted. And it's quite small, and it has to be recorded, and the clinical commissioning groups and the doctors have to record those offers or the actual gifts. And as you know, many gifts are offered. But the question is, once those gifts go above a certain level, and a country, I think every country should have a gift policy for health professionals, so that we know that above a certain amount is not acceptable. That actually it becomes much easier, because you know what happens. I know that, for instance, in family practices, sometimes a very small gift, such as a box of chocolates or something like that, is just given around. But the need to have it very clearly defined is what is the maximum amount of money that can be given in the form of a gift, and that the doctor has to declare that gift in his annual tax return and in his appraisal is very important.
Is it relevant to, Andrew, whether the gift is given before or after the treatment, and whether the treatment is conditional upon the gift in any sense?
Well, that's an interesting, and I'm speaking with a former surgeon. As I don't know if you know, but Dr. Peter Saunders is a trained surgeon, and so perhaps you want to, he may have been given gifts before he did the surgery. I would say no. Basically, from the point of view of the influence of the gift on the present treatment or the future treatment, it doesn't really matter whether it's given before or after. I think gifts of thank you are particularly important, because really you're not just saying thank you, you're anticipating for the next time. And that's why it has to be taken as seriously as a gift before the treatment.
Thank you. Now, you talked about the doctor or dentist gaining personally from that influencing treatment. And of course, not all gains are necessarily financial. But this next question talks about emotional gain. Regarding conflicts of interest, if a medical practitioner starts to become aware that a patient has romantic feelings towards them and returns these feelings, what's the correct legal response? And then on an ethical basis, what do you recommend doing in that sort of situation? Because this could quite conceivably influence treatment as well.
Okay, well, this is going way beyond this seminar, the issue of romantic feelings. There are clear guidelines about the unacceptability of personal relationships between a patient and a doctor. Those are separate issues, nothing to do with conflict of interest or corruption. And it's very clear that there are doctors whose lives have been damaged, and the people that they've been associated with have been damaged because they didn't admit to it and get it stopped and discuss it with their colleagues and how to manage. But I would say that the romantic feelings is different from conflict of interest and corruption.
Next question. Many other industries have fast-tracked options where you pay a little bit more to get preferential treatment. Even buying a book on Amazon, I think, for example. But given that other industries do this, is it wrong that is it unethical to do it in the medical or dental context? And if so, why?
This is a really important question, because as we all know, this is what happens in many situations in life. I think what I would do would be good to go back to my own situation where I had the option of going for waiting for 7 days for my goods, the medical supplies, to be cleared through customs in a port in Africa, or paying an extra amount for it to be cleared very rapidly. The question then is, where did that extra money go? You know very well that when you give a fast track fee, you are expecting that fee to go as a bribe to the officials. Similarly, when one is applying for an ethical permission to do a research study, I've had this where you have a fast track and a slow track. And if you have a slow track, basically that's the normal procedure, that the members of the ethics committee only basically sit perhaps every 1 month, every 2 months, and you just have to wait for them to review very carefully the research protocol. But you know that if you pay for a fast track, that money is actually going to the ethical committee members. So I think one has to be very discerning and very wise in making these decisions about fast track and slow track as to where do you think that extra money goes? And if it's going to actually just bribe somebody to give you something, that is very, very different from going to a marketing company where what you're doing is actually paying a different sort of people who work very fast in going around a warehouse and collecting that item and putting it in the mailbox. That is different from conflict of interest and corruption. So when it comes to the pharmaceuticals, again, one would say, well, what is the extra money being used for? One needs to be very discerning. There's no immediate right and wrong answer here. All I'm just saying is that these are highly toxic areas.
Thank you. Please keep your questions coming in, folk, and do upvote those questions you'd like to be asked. Question now from Philip Wood. It's just disappeared. No, here it is. In Africa, it's often understood that a missionary will not be required to pay a bribe, say to the police. However, our African colleagues tell me that they cannot live there without conforming to the norm and paying bribes. Do you have any advice? And these are situations where bribery is really absolutely endemic, I guess.
I have enormous privilege in being listening to a man that I last met 40 years ago, who spent all his 40 years of his professional life as a surgeon in DRC. And it's a great privilege to be asked a question by him. I think, Philip, I would just love to speak with you. But what I would say there is that there is a need to separate our medical corruption and conflict interest from things which go on in our society. I'm only talking about conflict and corruption in healthcare. What people do in terms of bribing police, in terms of bribing officials, that is a separate issue. And it's one that I would not wish to dispose of lightly, because I know, having lived in situations where I've been asked for bribes many, many occasions, and my colleagues locally have been asked for bribes on many occasions, that is a separate issue, a very tough one. And I honestly can't, in a nutshell, give a fair response to that, Philip. So I hope I would just say that if the corruption is like going for a work permit, going as I did for water supplies to a hospital, when actually I knew in my heart of hearts it wasn't fuel that I was being held up for. It was actually money by those guys. It worked and lives were saved, and it's a tough call. And I'm not saying there are easy answers. So within the medical sphere, I would say I think we have some guidelines from scripture, we have some guidelines from the Nolan principles, but those don't necessarily tell us how we should be responding in a community where life is endemically corrupt. Thank you, Philip.
Our next question builds on that from Hotlan Ompasungu in Indonesia, dentist in Indonesia. Corruption is rampant in Indonesia, including in healthcare. And this is happening because the system is very top down, so that it really at the very highest level there is corruption operating. What can we do as health professionals to change systemic corruption that is present endemically in a society? And I guess this is a question not so much about what we do personally as clinicians, but our wider responsibilities for advocacy in that society.
That's a really important question. Thank you so much for that. I should have gone into that, but it actually is referred to in the paper from the Christian Medical Fellowship paper on this topic. There was actually and I'm not going to get anybody into trouble, but there was a very clear account of what happened in Romania, where the officials who were stealing money that was meant to go for the treatment of people in different forms of healthcare were named and shamed. And as a result of that, they lost their jobs. And that was a brave thing for guys to do, but they were actually a small group of highly honorable doctors who said that is just not acceptable. It was in the sort of first and second aspects of corruption. So actually being bold enough, being brave enough, and making sure that you have support. If one person does it, it does seem to be that they could be horrifically punished, and that's tragic. in it. But if there was a group of people who somehow mustered public support for saying enough is enough, we are not going to do this, then they worked together. And the actual example was published in the Lancet, which is a journal which is widely available for free. And so you might like to look up the Romanian case study of how they responded to corruption at a very high level. I do not want to say this is easy, but these brave guys, women and men, did that, and they achieved something which was, to me, quite remarkable and splendid.
Thank you. This is a question more from a Western context, but many health practitioners process insurance claims in a way to maximize the chance of patients getting the care they need, and are often pressured by patients to do so. What are your, is that a form of corruption? And if so, what are your recommendations?
Yes, I must be quite honest. I don't have any experience of that, and nobody in our working group had any experience of that. I think it's a very helpful. We need to do more. Obviously, if there was an example where the doctor was being pressurized to give a report which favored the financial outcome of the individual who was insured, and there was a benefit to the doctor, either in his reputation or in his bank balance, that would be corruption. I can see no other way for that to be. I think what I would probably have to say is that we didn't really consider that within our group. It's a very important issue, and thank you for raising it. Perhaps you and others who are affected by that might like to work as a small group and seeing how you respond, but thank you for raising it. I don't have a particular answer.
Thank you. From Kizito Shisanya in Kenya. When viewed in context of practice in other fields or professions where there is official payment and receipting for fast tracking a service, so we're back to fast tracking again. For example, visa processing, there's a premium fee for quick service as opposed to regular standard waiting time and so on. Banking services. How does this affect the perception of fast tracking service in healthcare for a premium? I guess this might relate also to whether there is a two-tier service. You know, a mission hospital might have a private wing, for example, to provide treatment and gain more income. But could you comment more on that?
That's a really important point. Obviously, many mission hospitals, I'm going to use the word church hospitals, and private hospitals, basically in adjacent to church hospitals, they would charge more, and you'll get a different quality of service, and that everybody knows what they're doing. They go into a basic government hospital, or they go into a basic church hospital. They know what they're getting, and if they can afford it, they go. I don't see that as bribing. It's basically, it's a kind of, which car do we drive? Do we either Ford or we drive a Mercedes? Sorry if I've offended everybody who owns a Mercedes, but basically those are two levels of care which are appropriately costed. I don't see that as conflict or corruption. What has come up in the group was the practice whereby some government and church hospitals staff are given money by those running the private clinics to refer them to their clinic or their hospital as an incentive. That obviously is corruption, but just going to those high level, high quality, high fee levels, I cannot personally, and I don't think the group would say we would call that corruption.
Thank you. If we lump together pharmaceutical sponsorship with more serious corruption, do we inadvertently do a disservice to the serious corruption we find around the world?
I think we have to be very careful about what we mean by corruption around the world. That's the phrase you use, Peter, that comes in from the question. I think we have to be very specific. We're trained to be critical and analytical. when we're looking at every single situation of corruption, if it's possible to identify who is actually getting the extra kickback, who is actually getting an extra money, and what way are patients' care being compromised, that's very clear. I have to say that just saying, oh, this is all horrifically corrupt is important, because that's often how we feel there are. But I would say that we should use our brains to be very analytical, say, why is this particular piece of malpractice, whether it's political or whether it's social, whether it's being practiced, rather than just saying corruption around the world. Let's be very clear and careful in our comments. And what I would say is, again, when we're making comments about any form of conflict of interest, that we need to be able to be absolutely clear that we are supported by other people who see the situation the same way. I have, to be quite honest, I have not included anything about whistleblowing, but everybody, I think, on this seminar will know what I mean by whistleblowing. It is basically when somebody complains about a corrupt practice in healthcare or anywhere else. If that person is not able to whistleblow, that there's something wrong with the system. But if that person then is just allowed to say something without the claim being investigated by the authorities in a very careful way, then that is not correct. What we need to do in our integrity is to make sure that claims against pharmaceutical companies, against individuals, against corporates are basically thoroughly investigated and made clear as to what the issues are, how much money is going, and how many clinicians' minds are being changed by that. So again, I would be cautious about trying to give an overall statement about overall corruption.
Thank you. This will probably be our final question because of time. But unnecessary treatments, charging for unnecessary treatments. The question is given the example in the dental profession, there's not very good evidence for scales and cleans. In fact, it can cause damage to the patient's gums, but dentists do it routinely. And so now it's common practice because patients expect it. It's not nice to have calcifications in one's teeth. What's your advice for the believer? I know in surgical context, they used to talk about chronic remunerative cholecystitis, for example.
Well, I bow to your, I don't know much about remunerative cholecystitis, Peter, as a surgeon. You may or may not have been open to that. All I would say is that, again, one looks from an integrity and an evidence-based perspective. I would expect any doctor or dentist or nurse or any other health professional to look at the evidence base for what they achieve. So the picture that I showed was of a situation that I'm aware of, whereby many patients in a private clinic are given an intravenous infusion of saline, regardless of what the basic pathology is. That obviously has to be unacceptable. And I would say that as a general thing, there is no evidence that somebody who's able to sit up on a chair, who has got a normal blood pressure and has got, they're able to speak and swallow, that they don't necessarily need an intravenous infusion. But it's tempting by somebody who wants to charge for that. But again, one has to, as a doctor or a dentist, see what is the benefit to the patient in terms of the scale, in terms of the potential damage as a result of this. It would be, to my mind, evidence-based malpractice that we should be looking for.
Thank you very much. So transparency, evidence-based, integrity, and so on. Just a couple of comments from the chat here. The boldness from Paul Hudson, that boldness and courage to stand up against corruption where it is rampant must be found in the power of the Spirit of the Lord. The gospel does abundantly speak to this, as you're saying, Andrew. The roots of corruption are in a false idea that power is a passport to personal privilege. i.e. to lord it over others, in the words of Vishal Mangalwadi. And lots of people saying thanks so much for an informative and helpful presentation and for your answers to the questions. So I'm afraid we've run out of time, although there are still many more questions. So it just remains to me to say thank you again, Professor Andrew Tomkins, for speaking to us on corruption in healthcare. Thank you to our translators. Thank you for Josh doing all the technical work. And thank you very much for everyone for coming today and being part of this on ICMDA webinars. God bless you, and hope to see you next week.